Well, greetings, everyone. How are you? It's a real pleasure to welcome you to this month's podcast. As always, we're going to bring you up to date with the latest in the world of rheumatoid arthritis. Particularly interesting this time because we're going to talk about some papers from Xavier Mariette and Raffaella Di Napoli. And we're thinking mainly about the risk of major adverse cardiovascular events, venous thromboembolism, and malignancies in patients with RA or UC treated with filgotinib. And we're going to assess whether the frequency of reporting of MACE, MI stroke differed between JAK inhibitors and TNF inhibitors. So really topical, pertinent. The field just refuses to lie down here. We're continuing to get more data as we progress. And as always, if you want to access detailed summary slides for the papers I'm talking about today, head along to imidforum.com. So that's imidforum, one word, .com. And it's a fabulous resource, papers, summaries, slides that you can use for your own use, or if you've got a ward round or teaching session, that's what they're there for. They're there so that we can all just share the joy of knowledge in this amazingly interesting area. So let me turn to the first paper, major adverse cardiovascular thromboembolic and malignancy events in the filgotinib rheumatoid arthritis and ulcerative colitis clinical development programs. It's quite a mouthful, but it does actually tell us what it says in the paper. Now, I think you're all aware filgotinib is a JAK inhibitor. It's approved in EU, UK, Japan for the treatment of RA and UC. An integrated safety analysis of filgotinib in patients with UC incidence rates of MACE and VTE were comparable with placebo and generally similar across filgotinib doses. This was a post-hoc analysis to look in a more detailed way at an integrated clinical study data set to assess the risk of key adverse events, all of them triggered by black box warnings and concerns about this general class of drugs. So MACE, VTE, malignancies in patients with RA or UC treated with filgotinib, and to look at maybe risk factors associated with these adverse events of special interest. So what were the results? Well, the incidence rates of MACE, VTE, malignancy, and non-melanoma skin cancer were low across filgotinib-treated patients with RA or UC in the parent studies and the integrated analysis. So far, so good. That's pretty much what we've seen across the board. Time to event analysis showed that occurrence of malignancy and non-melanoma skin cancer events in RA were generally lower even over time and did not increase with longer exposure to treatment. Time to event analysis in UC showed MACE and VT events were generally occurring evenly over time, and the time to onset was similar between filgotinib 200 and 100 milligram dose groups. In patients with RA aged more than or equal to 65 years receiving filgotinib 200, exposure-adjusted incidence rate for VTE was 0.3. In patients with RA aged more than or equal to 65 years, rates of malignancies and non-melanoma skin cancer were numerically higher with filgotinib 200 compared with 100. There were no VT events occurring in patients with UC aged more than or equal to 65. So this is, if you like, a factual description of events. The data seem to be consistent with overall safety analyses, generally low rates. But of course, the trouble is these are not common events, and that means we do need to be very acute in the way in which we look at data sets. Numerically increased rates of adverse events of interest occurred in patients aged over than or equal to 65 years. And that means the conclusion is we're going to need more data. And as we accrue more and more data, eventually I think that level of confidence will improve. But at this stage, in this analysis, there was no consistent filgotinib dose effect on these adverse events of interest. Now, what about a paper from Di Napoli and colleagues? This is major adverse cardiovascular events related to JAK inhibitors. This is a disproportionality analysis using the WHO Global Individual Case Safety Database. So again, background to this one, cardiovascular disease is a leading cause of mortality in RA. But in addition to that, the JAK inhibitors used to treat RA have been attributed the potential to cause a risk to cardiovascular safety. This led to the FDA public warning regarding increased risk of serious heart problems and cancer associated with tofacitinib. That was back in 2021. Now, in EULAR, we've placed JAK inhibitors in the same level as biologic DMARDs, but only in patients whom cardiovascular and malignant risk factors have been excluded. And despite established recommendations, there's limited evidence on MACE in elderly and adult populations in real-world settings, and lack of studies analysing individual MACE events. All that said, of course, we do pay close attention to the oral surveillance trial. This study describes MACE and events collected in WHO Individual Case Safety Report database. Data were used to assess whether frequency of reporting of MACE, MI, and stroke differed between JAK inhibitors and TNF inhibitors. So, key results here: female and elderly patients showed increased representation in MACE exposed to JAK inhibitors compared with those exposed to TNF inhibitors. Cumulative frequency of time to onset of MACE occurrence appeared different between JAK inhibitors and anti-TNFs, with median time to onset of 210 days for JAK inhibitors and 690 days for TNF inhibitors. Among the 2,543 MACE cases associated with JAKs, 1,262 were non-fatal strokes, 814 non-fatal MI, and 510 were fatal cardiovascular events. Total of 1,365 stroke cases and 906 MI cases. JAK inhibitors were significantly associated with a higher frequency of reporting of MACE, non-fatal stroke, total stroke, MI, fatal cardiovascular disease compared with those receiving TNF inhibitors. Concerning gender, in particular, JAK inhibitors were associated with higher frequency of MACE in both men and women compared with anti-TNFs. And concerning age, JAK inhibitors showed significantly higher MACE in patients less than 65 years. No significance observed in patients aged more than or equal to 65 years. What do we draw from this? This is consistent with an increased frequency of reported MACE with JAK inhibitors compared with TNF inhibitors. By and large, the WHO Global Pharmacovigilance database is consistent with some previous studies. The cardiovascular profile in these two classes were different. JAK inhibitors were more associated with stroke, with shorter time to onset compared with TNF inhibitors. So we now need to dive into that deeper level of detail. And as before, overall, I would conclude that we need to follow the FDA and EMA advice on the use of JAK inhibitors in patients with inflammatory arthritis. More data needed, which is a slightly depressing but also a truthful statement. So if you want to look at the full publications uploaded this month and access our other podcasts and resources, head across to imedforum.com. As I say, it's a treasure trove of great information, and it's easy and quick, so you just get there, it's all there for you. Makes life just that bit simpler in our busy clinical existences. So don't forget, by the way, to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel. Make sure you don't miss our podcasts in the future. And please do leave a review. Let me know what you're thinking. Thank you for coming along to the podcast. Really do appreciate your attention. I hope it's helpful, and I wish you the very best of luck in your clinical practice. Thank you very much indeed.